anywhere in the hospital. But one thing is true, whenever you're using an ultrasound to look at a patient's pregnancy, the patient is really cued into what the doctors are doing. They're looking at the doctors, they're looking for any facial expressions that could mean positive or negative regarding the status of their fetus, and so you really want to be careful there when you're doing one of these ultrasounds. You can see she looks up for a second, they shush her, put her head back down on the table, and that's really not the best way to interact with your patient. That guy did it too, and you can see they look very concerned there, and the patient is I don't know, somebody sent me that. I wasn't sure where to put it, but that seems to be the right location for it, so I was just kidding about all that. So, so with the pelvis, the pelvic anatomy can be a little bit confusing, and so we're just going to review it briefly here. In the upright female, the pelvis is already tilted back at 45 degrees, and so right off the bat, things are confusing, okay? And, you know, you've got the various cul-de-sacs. You've got the posterior cul-de-sac, which is the recto-uterine pouch. It's the space between the rectum and the uterus. This is the posterior cul-de-sac, also known as the pouch of Douglas. And then you've got the anterior cul-de-sac, which is the area between the uterus and the bladder. And that's anterior as opposed to, this is the posterior cul-de-sac. Anyways, the vaginal vault is at a 90-degree angle to the normal anteverted uterus. And so now we've got this 90 degrees. This is the external iliac vessel, and sometimes it's really hard to find the ovaries on ultrasound, but if you just can remember that the ovaries are anterior and medial to those iliacs, right on top of it, just medial to it. But in the first trimester of pregnancy is what we're going to be talking a lot about in this talk, because that's when a lot of interesting embryology and physiology is going on. So recall that for a patient to get pregnant, there has to be ovulation. And so on any given ovary, you can see different follicles here of different ages. And so that's why on ultrasound, an ovary will appear like a chocolate chip cookie, the chocolate chips being the different follicles. The normal size of an ovary is about 2 by 3 by 3 centimeters, and they have these anechoic follicles on them. Well, eventually, each month, one of the ovaries will pop out an egg, and the egg will make its way into the fimbria of the fallopian tube, and ovulation or fertilization happens way out here, way distally. So you can see as this egg is making its way down through the fallopian tube, there's many places upon which it can get stuck and become a tubal, or otherwise known as an ectopic pregnancy. So it has to kind of make its way all the way over into the uterus until it embeds itself into the wall of its host. And when it does so, it looks like this. This is the uterine lining here, okay? And this is that embryo that's embedded itself into the wall of the uterus. This right here is called the embryonic disc. This is the first bunch of cells that are going to line up to become the baby. And this structure right here is called the yolk sac. So the yolk sac actually is the only thing that's identifiable initially inside the gestational sac. So what do I mean by that? Right at about 5 weeks, this is what we see on endovaginal ultrasound. We see the uterus out here. This structure right here is called the gestational sac. Okay, it corresponds to this whole gestational sac over here, basically the embryo. And this little thing here, I used to think was the baby's head. It's just this yolk sac. Okay, this minimal sac diameter, gestational sac diameter, should be at least 5 millimeters in that at this first stage of pregnancy at 5 weeks. IUP is intrauterine pregnancy. Feel free to stop me on any of these abbreviations in here. I like stopping like that. Yes, another question?
Where's the probe located?
The probe footprint is seen up here. It's in the vagina. This is the endovaginal transducer. We're going to come right back to that, but before we show you exactly where the transducer is, I just want you to think about the different stages of development after implantation that we see on ultrasound. Yes?
Is there a reason to be doing it? 5 weeks?
Yeah, so what's the reason to be what's the indication to be doing this? The indication is basically a patient has pregnancy and maybe some vaginal bleeding or abdominal pain, and the patient's really worried that she's having a miscarriage, and the doctor is really worried she's having an ectopic pregnancy. So that's why this ultrasound kind of, it's the sound that binds us in that situation, brings us all together, and allows us to communicate with one another. Yes?
Follicles on ovaries of women on birth control?
Yeah, so follicles on women on birth control, yeah. You can see follicles on there sometimes, absolutely. After menopause, though, you shouldn't see any more follicles there. Anything on an ovary after menopause is considered suspicious for cancer until proven otherwise. So, moving on, that's 5 weeks. That yolk sac is seen there. And then at 6 weeks, that embryonic disc now gets large enough to look like this little larvae structure here. And on ultrasound, well, here's that yolk sac. It's starting to obliterate. We can still make out the yolk sac here at 6 weeks, but adjacent to the yolk sac is that little fetal pole. Okay, so the fetal pole starts to emerge. We can see that embryonic disc now take on what looks like on ultrasound a little grain of rice. Okay, so 5 weeks, yolk sac, 6 weeks, fetal pole, and then 6.5 to 7 weeks, we see that fetal pole start to take life, and we can see a little heartbeat there. And so we actually term this, it goes from being an IUP to a live IUP. From an intrauterus, the heart turns on and starts to flicker. That they're termed as live intrauterine pregnancy. It happens right about 6.5 to 7 weeks. And so what we're seeing here, this is the fetus adjacent to the yolk sac. The yolk sac's still there. It obliterates over time. Probably around 8 or 9 weeks, it's totally gone. This is a little piece of the amniotic sac. That's nothing that's happening during that first trimester, is that this amnion here is going to expand to replace the contents of the gestational sac to become just the amniotic sac, the amniotic fluid. And so that's what's also happening. So now over here on this particular drawn out diagram, later on in pregnancy, maybe 9 weeks or so, not seen on the ultrasound here, but now there's no more of the gestational sac. The gestational sac is actually all this amniotic sac seen here. And that's what you're seeing, just a little piece of the amnion is coming into view here on this ultrasound. So there's this other term that I don't really like, and it's called the double decidual sac sign, and it's where you have the decidua basalis of the uterus comes in contact with the decidua capsularis of the growing fetus. And what happens is, on ultrasound, you see these two structures come in contact, and you can actually call a pregnancy even earlier than 5 weeks using ultrasound based on the double decidual sac sign. And that's what radiologists tend to do, but I think that it's a little risky because you can have this thing called a pseudogestational of intrauterine pregnancy. When a pregnancy is growing outside of the uterus is still responding to some of those hormones, so an endometrial reaction still occurs in the setting of a tubal or ectopic pregnancy. And that's what is called a pseudogestational sac, and that's how you can get burned in this first trimester and call something intrauterine when in reality there was actually something really small growing out in the adnexa that you didn't see. So I think in order to be safe with all this, you wait until you see at least a yolk sac inside the gestational sac. You see a pseudogestational sac will never have a yolk sac in it or a fetal pole. So that gestational sac should have something in it to be an intrauterine pregnancy. If it doesn't, there's no definitive intrauterine pregnancy there. Yes?
So if you see this, then do you go look to see if there's an ectopic pregnancy?
Yeah, absolutely. Even so, to answer your question, if I see a double decidual sac sign, basically it's an empty gestational sac, I absolutely look in the adnexa very carefully for any masses in the adnexa, any ectopics, absolutely. Now, if a patient is not taking fertility medication, she just gets pregnant naturally without fertility medication, the chance of having an intrauterine and extrauterine pregnancy at the same time, what we call heterotopic pregnancy, is very rare. It's like 1 in 7,000 probably. But if you're taking fertility medications like Clomid or all those other injectable medications that women take to increase their chances for getting pregnant, then the chance of heterotopic pregnancy is 1 in 100. So you could have, so a woman comes to my emergency department with first trimester vaginal bleeding or abdominal pain, and I see an intrauterine pregnancy. Getting back to your question, I still really look very closely for an extrauterine pregnancy if she's taking fertility medications. Make sense? All right. Moving on. There's 2 ways to image the pelvis: transabdominally, which is where the probe is just above the pubic symphysis, using the bladder as you go through some pros and cons of both approaches. So transabdominally, some pros and cons. The pros, it's less invasive. And I kind of take that to mean there's less of, the taboo of this physician coming in the room, putting something in the vagina, needing a chaperone to be there and stuff. It's it's less invasive, you know what I mean? And so that's the good news. And if you've got some really large object in the pelvis that's taking up a huge amount of real estate in the pelvis, when you look endovaginally, sometimes all you see is just just a bunch of fluid. Whereas when you look transabdominally, you can trace a very large object all around the pelvis and see what the heck it is attached to. So as an example, I had a woman who had a 19-liter ovarian cyst, okay? And I put the endovag probe in there initially, and I just saw like black on the screen, nothing. I mean, I moved the probe in any direction, it was just totally black. And so transabdominally, I was able to follow the thing around and see what the heck it was. So that's one thing. However, because transabdominally you're using a lower frequency probe, that C60 you're seeing there is 3.5 to 5 megahertz, so we don't have the best image quality as opposed to when we get to use the endovag probe, which is like 7.5 to 10 megahertz. Okay, so we lose resolution looking transabdominally. And if you have a patient who's really obese, then you have to get the sound to penetrate through all that tissue to get down all the way down to the pelvic contents. It can be very difficult to see anything meaningful at all in that situation. And imagine drinking a 12-pack of beer and then taking your belt buckle and cinching it down as hard as you can over your bladder. That's what this feels like. It's quite uncomfortable to do this to patients sometimes because you're pushing down really hard on a full bladder, which is what we're going to do today to our models, and that can be uncomfortable. Because really, ideally, you want to have a full bladder if you have any chance to see the ovaries and the pelvic contents. Now, endovaginally, the good news is you got the high-frequency probe, way better resolution. It's more comfortable to patients. Ultrasound done on me, obviously. But I've done about 3,000 of them, and I get constant feedback when I do this, especially a patient who's never had them before. They look at the transducer, they're like, whoa, 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 what's going on here? And I have to kind of like talk them into it, and they're like looking at me like, you don't know what this is like. And I'm like, yeah, but I've done a lot of these. So what I can tell you, is because you have an empty bladder, unless there's a laceration in the vagina, or unless the patient's got rip-roaring infection in the pelvis, like pelvic inflammatory disease or cervicitis, this is actually a very well-tolerated, much more comfortable exam than going transabdominally is. And so that's just based on my talking to lots of patients about it. Because afterwards I was asking, so was that really bad? No, that was nothing, thinking, whatever. So, but just keep in mind, since you're using a high-frequency transducer, that the sound can't penetrate that far. So don't expect to see organs like the kidneys and, even really other stuff like appendicitis and things like that, even in the abdomen and intestines. All you can really see is the uterus and the ovaries next to them because that sound can't penetrate very far. It's such a high frequency probe. And when you scan from within inside a body cavity, the anatomy is initially a little bit confusing. So I'm going to try to obviate some of that for you in the rest of this talk. So transabdominally, we're going to start there. And you guys know this from just looking at bladders and stuff. The indicators towards the patient's head in the sagittal view, and the indicators to the patient's right in a transverse view. So going back to sagittal, the indicator of the patient's head, this is what we see. We see the bladder as a triangular shaped structure, and we see the uterus right behind the bladder. And this is the vaginal vault right here, or we call the vaginal stripe. It's got a white line. It's where the walls of in an empty vagina, the walls come together. It makes a hyperechoic line. And it's the true midline of the body right here, the vaginal stripe. So this is like the outside world, and then this is the vaginal stripe. It terminates at the cervix, and then in the anteverted uterus, it's going out this way in that direction there at a 90-degree angle. With a relatively full bladder, you'll see a 90-degree angle here. Now, if the bladder was empty, well, then this uterine fundus comes all the way back over this way, almost 180 degrees all the way back towards the vaginal stripe. And I know that sounds a little bit confusing initially, but over time that becomes really obvious. This is the anterior cul-de-sac up here. It's the vesico-uterine pouch. Back here, this is all the posterior cul-de-sac or pouch of Douglas, the recto-uterine pouch. Now, moving to the transverse view, the indicator is the patient's right. This is the uterus seen behind the rectangular-shaped bladder. And if you have a really large bladder, sometimes you can make out things like the ovaries. So some people say this looks like an elk with its antlers out here, or it looks like a koala bear with its little ears. You hear all these things. And you always got to be careful when you're teaching the bedside and saying things like elk and antlers and chocolate chip cookies and things like that, patients get a little weird sometimes when they hear you talk about that. This is the problem here. So this is an empty bladder, transabdominal approach with an empty bladder. The anatomy gets really confusing here, I think. So this is actually like the rectum down here. There's a little air in it, right down here. This is the vaginal stripe right here. And then the uterus goes behind the screen and then comes back out at you. And at the top is the fundus of the uterus up here, going kind of behind the bladder and then back out again when the bladder's not full. Okay, so that's a little bit strange looking transabdominally with an empty bladder. So don't freak out if you see that today. Go back to sagittal. I think the anatomy is a lot easier to see in the sagittal view. Now, endovaginally, you've got the probe. When it's in a sagittal view, the indicator's towards the ceiling, okay? Indicator's towards the ceiling in a sagittal view. And then in the transverse, what we reterm coronal, because we're sort of coming from inside the body, the indicator's to the patient's right. So this is the indicator on this transducer, this little notch. So it's towards the ceiling sagittally to the patient's right coronally. Now, check this out. You got to have the patient up on a stack of towels, their buttocks elevated up on a stack of towels, or preferably in a gynecologic table with their feet up in the stirrups, with their buttocks towards the end of the table. The reason I say that is because in order to look more anteriorly, this handle right here is going to have to go down towards the floor. So you need to move the handle down towards the floor to look up more anteriorly. And the only way to do that, because if the patient's sitting on just a bed with their legs in a frog leg position, the handle hits the gurney, okay? But if their buttocks are elevated in the air on a stack of towels, well, now the handle can go down and you can look anteriorly. Now, if that doesn't make sense, it's about to, I promise. Now, coronally, the indicator is the patient's right, and it's also, you can think of this as a short axis or transverse view. Here's the other problem, is that you need to have an empty bladder when you go endovaginally. And the reason is because a full bladder causes all these crazy artifacts. And this is some artifact that's covering up our gestational sac right now. So it's a problem because you have to, and you tell the patient that they have to go and, you take the transducer out, they go void, and then you have to refine your, slows everything down. So I really try to make sure they have an empty bladder from the get-go so you don't have to redo this exam, okay? Because right now we can't tell whether this is a gestational sac or a yolk sac or a fetal pole or anything really going on inside this fundus of this uterus here because of all that artifact. So empty bladder, endovaginal. Now, here's how I'm going to help you understand this anatomy, which is a little confusing initially. So this schematic diagram is the sagittal view transabdominally. I know it says endovag, we're getting there. This is actually the transabdominal, like C60 view of the uterus, the bladder, the cervix, and the vaginal stripe. Now, watch what happens when let's pretend we have a gymnast that does a handstand, okay? I know that sounds a little bit creepy. I didn't come up with this analogy, my boss did, so just so you know. The gymnast does a handstand. Now, the vaginal stripe vault is pointed towards the ceiling, okay? Now imagine we took a transducer and placed it in the vaginal vault on this handstand person, and the sound comes out in this way. And this is the sector that you see on the ultrasound screen, right? It comes from the top of the screen on down, and you catch a little sliver of the bladder there, and you get the base of the uterus and the cervix. So this is what you see when you put the probe straight in, is mostly cervix and uterine base. Now, let's say you wanted to see the fundus of the uterus. You want to be able to see up here where the fundus is. Which way do you need to move the transducer? I should say, which way do you need to tilt? Towards the floor or towards the ceiling? So the handle will be pushed down towards the floor. That will get the sound to go up here towards the fundus. Does that make sense? Now, if you understand that, you pretty much got it. So I'm just going to say it one more time. The sound's coming out through the base of the uterus and the cervix. That's what we always see right when we put the probe in. But immediately you got to drop the handle down towards the floor, and the only way you can do that is if the patient's buttocks are elevated or they're in a gynecologic table. Because that's how you get to see the fundus of the uterus. And it looks like this. So here's that transabdominal view again that we saw earlier with the triangular shaped bladder. How do I know this is not an endovaginal ultrasound? Well, because I can see this is the vaginal stripe on an endovaginal ultrasound, because that's where the probe's sitting. Okay, so you rotate this, you put the probe in, excuse me, and this is what the view is, here's your bladder now much more empty than it was here. The sound is in the vaginal vault. It does catch part of the bladder, and then we move the handle down towards the feet, so we're looking up anteriorly at the fundus of the uterus. This is the endometrial stripe seen here. Cool? All right, moving on. Now, if we move the probe in the right plane, sometimes we can see everything at once. Okay, because remember, this transducer has 180 degrees of view, so we can see a little sliver of the bladder here. We can see the anterior cul-de-sac or vesicouterine pouch. This is all the anterior cul-de-sac. Here's the fundus. And this is all the posterior cul-de-sac back here. And this person's got a little bit of free fluid seen here in their posterior cul-de-sac. But I can see everything from her cervix all the way through the endometrial stripe to the fundus, even part of the bladder here. That's what's so nice about having a big, wide curvature of view on these endovaginal transducers. Okay, that posterior, here's your anterior cul-de-sac, here's your posterior cul-de-sac. There's a little bit of free fluid. Now, it's normal to see free fluid rolling around in the female pelvis. We see it all the time because remember when that ovary got popped out of that, that egg got popped out of that ovary, well, it left behind that little follicle there. Well, that follicle has some fluid in it that leaked down into the pelvis. Now, depending on how big that follicle gets during that cycle, maybe it skips a couple cycles and it gets really big before it finally ovulates, well, it could leave behind quite a bit of fluid. And so that's what this is, just normal fluid seen in the posterior cul-de-sac on this female. Now, it's always abnormal to see any fluid in the pelvis of a male or a woman after she has menopause. Okay. Now, the indicator on the transducer is this is the indicator up here on this particular transducer. It's towards the ceiling on a sagittal view, but you rotate it towards the patient's right on a coronal view. So that indicator goes to the patient's right leg when we're going coronally or short axis. And this is when we see a little sliver of bladder. Again, we're endovaginal, so the bladder should be nice and empty. And then we're seeing behind the bladder in its short axis a coronal view of the uterus. And this is like where the gestational sac is located here. So over here is the patient's right. No, I'm sorry. Over here is the patient's left, and over here is the patient's right. It's confusing for me because I'm looking the opposite direction that you guys are looking. So to find the ovaries, it's a bit of a art. Okay. So what I do is I start in the sagittal plane, endovaginally, and I slide out to the patient's lateral area. So basically, I always look at the left ovary first. I kind of do it in the same way every time so I don't forget any steps. I find the uterus in a nice sagittal plane, and I slide out laterally in that sagittal plane until I see one of the iliac vessels. Sometimes it requires me to insert the wand a little further, but eventually that iliac pops on my screen, and then the ovary should just be anterior medial to that iliac vessel. Okay, and it looks like this. This is what a normal ovary looks like. It's about 2 by 2 by 3 centimeters. I wasn't lying when I said they look like chocolate chip cookies. You can see these follicles of different ages here look like little chocolate chips on a cookie. And the patient will say to you, "How'd you know what I eat for lunch? Man, that ultrasound machine's amazing." This is the iliac vessel over here. One iliac is there, and then the other iliac is here. So we look at both ovaries. I just cut the clip there. Now, transabdominally, a little tougher. Okay, this is the ovary down here transabdominally. They've got a pretty full bladder, which is good. They're pushing really hard because these loops of bowel over here are always trying to get in the way of your ovary. So if you push hard enough, the loops of bowel kind of squirt off to the side. The patient is in agony as you're pushing down on their bladder, but then you can see there's this ovary sitting out here adjacent to the bladder. The iliac is not far behind it. I don't see it here. I think the iliac is probably in this region right here where all this is all bowel gas obscuring our view. So air can cause things to look dark or bright. It's variable. But one thing, air is the enemy of ultrasound. So let's take this case. Here's a 17-year-old female. She comes in the emergency department. She's pregnant. Her urine pregnancy test is positive. She comes in the ER with lower abdominal pain. Maybe she comes into your clinic that way in primary care. I don't know. But this is what you're faced with, this ultrasound. This is an endovaginal ultrasound. How do I know? Because it says ICT right here, intracavity. So we're looking in her pelvis, and what do we see? Well, first thing we see is this is a little bit, the depth of this is a little bit too shallow. We should go a little deeper. Why? Because here's the uterus, and it's kind of fallen off the screen here. So yeah, I'd like to see a little bit more of that uterus. I probably would take the depth down to 7 from 6.5. Well, this is the gestational sac right here, and this is a fetus. It's inside the gestational sac. The gestational sac is inside the uterus, so this is an intrauterine pregnancy. Whether or not it's a live intrauterine pregnancy or not, I'm not sure. I didn't really look at the video. I was more concerned with this thing over here. So we come over here. What's this? A cystic structure on the ovary, okay? And these are 1 centimeter hash marks. Until a cyst gets to 2.5 centimeters, it's not a cyst. It's not an ovarian cyst. It's termed a cystic structure on the ovary. It's a kind of a saying there. So to say a patient has an ovarian cyst, it's got to be at least 2.5 centimeters. Now, what happens during pregnancy? That's a big question, I know. Where do babies come from? That's the question I ask it. No. So what happens during pregnancy is that egg that pops out of that ovary leaves behind that follicle, and then that follicle can grow. That's the corpus luteum of the pregnancy, and that's exactly what we're seeing here. This is a corpus luteal cyst of pregnancy. It's totally normal to see that, but it brings a lot of patients to our clinics and ERs because they get abdominal pain from this cystic structure sitting on that ovary. Now, if they're taking fertility medication, well, then I have to be careful there's not an ectopic right here, because there is a mass out there. Yes?
Can you see the ovary?
The ovarian stromal tissue is this material seen here. In fact, there's another little follicle right there on it. And it comes over here, so there's really like a cyst here, and there's like another cyst right here. There's a cystic structure here, I should say, another cystic structure there. Now, what about this patient? This is a 22-year-old female. This one's not pregnant, but she's got all this crazy right lower quadrant abdominal pain. This is also the endovaginal transducer. And what do you see going on here? See if I can stop it here. A little better. Okay. So, endovaginal transducer. This is the uterus. And there's something else over here. It looks kind of like the uterus, but it's not the uterus. What is this? It's a cyst. I like that answer, fibroid, but it's not. This is a cyst, a special kind of cyst that when it ruptures, it really irritates the peritoneum because it's filled with, anybody? Blood. This is a hemorrhagic ovarian cyst. Look how big it is. These are 1 centimeter hash marks. It's like, I don't know, 5 centimeters or something. So here's the thing. When a cyst ruptures, if it's just filled with regular fluid, sometimes it causes some chemical irritation that's always irritating to the peritoneum. So when this ruptures, it's going to cause a lot of symptoms down there. Anyways, that's what hemorrhagic ovarian cyst looks like. Yes? UCG is the urine pregnancy test. It stands for urine chorionic gonadotropin. UCG, urine chorionic gonadotropin. It's a urine pregnancy test. What's the serum beta human chorionic gonadotropin? I don't usually say all these words. I usually just say when the serum beta HCG gets above about 20, it'll ding a positive urine pregnancy test.
Where's the bladder?
The bladder's just out of the view here. It's going to be right up here. See it now? Right up here. Okay, so there's lots of reasons to learn this, but this was a case I had that was really important to know how to do this with. This lady, this is the actual patient. I smudged out her face so you can't see her, but I took a picture of her in the ICU the next day, which was good because she survived. She actually left the hospital about a week later. But this is how it all started. She was very sick initially. She came in, she's a 22-year-old female. She's having an asthma attack witnessed by the next door neighbor. Well, she was bradycardic, hypotensive, and cyanotic in the field. And when the paramedics brought her to me, she was in pulseless electrical activity, meaning that she had no pulse, but she did have electrical activity on the monitor. And so, you know, we're doing CPR, she's basically coding. And the interesting thing was that we're bagging her, so she's intubated, and we're squeezing the bag to make her breathe, and her lungs are clear. It doesn't sound like asthma at all. In fact, she's really easy to bag. So it wasn't really kind of lining up with an asthma exacerbation. You're given this information from the field sometimes, and, you know, the paramedics were dealing with, and then it turns out to be misleading. Then it didn't make sense. So then we thought, well, maybe she was found down outside in front of her house. Maybe she was hit by a car or fell out of a tree or something. So we did a fast scan, focused assessment of sonography and trauma, which was positive. We saw this fluid sitting here between her liver and her kidney. What does that mean? She has some fluid in her peritoneal cavity. Okay, we don't know whether it's blood or not, but there's an anechoic wedge of fluid seen between her liver and her kidney in Morrison's pouch. That's the most dependent portion of the peritoneal cavity. And so we know she's got fluid in her abdomen, and we got to find out what it's from. Well, we trauma. She's got no bruises, no abrasions, scratches, nothing. So then we start to kind of like put it together. Okay, we got this woman of childbearing age who's got fluid in her abdomen. It's time for endovaginal ultrasound. Look over here, right here. Watch that. She's got active bleeding in her pelvis. This is what we saw in endovaginal ultrasound. Now, she's in shock, right? So we don't even have any urine coming back in a Foley yet. We're trying to pipette out any urine we can get to send off for a pregnancy test. So we don't even have a pregnancy test back yet, but we made the diagnosis of ruptured ectopic pregnancy, called OBGYN. They came down to the bedside. When they see these images, it means a lot to them because they're really good at ultrasound. They immediately took her to the operating room, and she survived. So without ultrasound, I don't know if she would have survived. We would have been going down all these wild goose chases and giving her, stuff to treat asthma initially, and then maybe even done a laparotomy. I don't know what we would have done. Who knows? But I don't know if we ever would have got to the diagnosis of ruptured ectopic in time. So that's how the ultrasound really made a big difference. And I've had lots and lots of cases like that since, but that was my very first one involving pelvic ultrasound, so I'd like to share that one. In that first trimester, I don't want to bog you down with too many details, but there's like 5 different things you could diagnose in the first trimester of pregnancy, okay? The pregnancy can be in the uterus. If it's in the uterus, it can be live. It can be, meaning it's got a heartbeat. It can be early, just a gestational sac with a yolk sac in it, or a fetal pole that doesn't have a flicker on it yet. Or it could be an impending miscarriage or an abnormal intrauterine pregnancy. It can be outside the uterus, like an ectopic or tubal pregnancy, or my favorite category, you can't find it. The patient's pregnant, you put the probe in, and you don't see anything at all. It doesn't make any sense. And that's a pretty fun category because it turns out once you reach this diagnosis, up to 40% of the time these are actually ectopic pregnancies. And so they're pretty risky patients. So, early intrauterine pregnancy, here's your gestational sac. It lies within the endometrial echo of the uterus. So there's a gestational sac, and there's something in it, like in this case, a yolk sac. Oh, and the gestational sac, well, it measures at least 5 millimeters of internal diameter, and that's how you define an early intrauterine pregnancy. It's a gestational sac that's at least 5 millimeters in the uterus that can. So if this was just empty, a radiologist would come along and say, "Oh, look, a double decidual sac." So, I don't know, maybe there's maybe this is a pseudogestational sac of ectopic pregnancy, but because we see something in there, a yolk sac or fetal pole, definitely say this is an intrauterine pregnancy. Now, once that fetal pole develops a little cardiac flicker, okay, little flicker, I don't know if you can see it or not, it's sort of subtle, but once the heart turns on, then it's a live IUP. You still need to have at least 5 millimeters of internal diameter size of the gestational sac. But once the gestational sac just keeps on growing, it gets to 10 millimeters and doesn't grow a yolk sac, then it's an abnormal intrauterine pregnancy. It's got what? Okay? And that's very good, useful information to pass along. So a lot of people think that when you see a completely empty but abnormally large gestational sac like we see here, okay, a lot of people think that haploid gamete that didn't get fertilized yet set up this reaction in the uterus to make it look like there's a pregnancy going on. So a pregnancy test, but never really had been pregnant, and that causes a lot of confusion, as you could imagine, socially with certain situations. But this is that's termed a blighted ovum, and that's what this looks like. It's like this. Now, the other type of abnormal intrauterine pregnancy you can have is more common than this. I just wanted to point out what a blighted ovum was for you. The other type is more common, and this is when you actually see a baby that's at least 5 of crown rump. Okay, so from the crown down to the rump. Okay, if this is the head and the butt is down here, you measure this distance, and if it's more than 5 millimeters and there's no heartbeat on, then that's going to be a miscarriage 100% of the time. Yes.
If you see the heartbeat, not this one, but going back, you said that even when you see the heartbeat, it has to be larger than.
The gestational sac itself should be at least 5 millimeters, even if you see a heartbeat in there. But you know what? You won't see a heartbeat in there if it's not 5 millimeters. So it's kind of a misnomer to say that. But the criteria is minimum sac diameter of 5 millimeters to be called an intrauterine pregnancy or a live intrauterine pregnancy, yes. It just so happens that if your fetal pole is more than that same number, 5 millimeters again, and there's no cardiac activity, you can tell the patient. I usually say something like, this is nature's way of preventing birth defects, the DNA didn't line up right, or, I used to say it something like that, maybe a little bit more compassionately, but that's kind of how you didn't cause this, nothing you did, all that stuff. So, yeah. Now there's the other one, which is ectopic, extrauterine gestation, where gestational sac, 5 millimeters internal diameter, that instead of being in the uterus is outside the uterus. And this is this on endovaginal ultrasound, and this is what this ectopic looked like transabdominally seen on that left side adjacent to the uterus. So transabdominally, we can even see it. And then finally, no definitive intrauterine pregnancy. The uterus looks like it's empty. Whoa, what's going on? Why is your uterus empty if you're pregnant? Wow, you may really have an ectopic. But you look out in the fallopian tubes near the ovaries, and you don't even see any masses or anything out there. So you don't see an ectopic, you don't see an intrauterine pregnancy. Maybe the patient already had a miscarriage. Maybe they had a lot of vaginal bleeding, past some tissue came in. Their pregnancy test is still positive, but their uterus is empty. Or, which is what this category is right here, maybe it's so early yet, it's not just set, it's 3 weeks, they're only 3 weeks pregnant or something, it's just not setting up enough of an endometrial reaction, or maybe there's an ectopic. So up to 40% of the time, the answer is number 3, which is why these patients are a little dangerous to deal with. Now, in that first trimester, 60% single living IUP, 14% IUP, abnormal IUP picks up another 8%, 17% are no definitive IUPs. Only about 3% of the time do we actually make the diagnosis of ectopic pregnancy or extrauterine gestation at that visit. That being said, we see 2 to 3 ectopics per month in our ER UCI. So it's pretty common, actually, to see these ectopic pregnancies, which is why I spent all that time telling you about it. What do you think about this ultrasound? Well, it's basically just what you're probably going to see a lot of today. This is a relatively empty bladder. This is that stripe, the vaginal stripe. It's coming over to the surface itself all the way back towards the bladder because the bladder's so empty. So we have like almost 180 degrees of anteversion, it's called. So this is just a normal looking sagittal transabdominal anatomy. This, on the other hand, has some findings here. So this is the right, seen right here, and on this ovary there's a couple of large cystic structures on it. So here's that ovary, and then we've got 1, 2, maybe even a third one. And there's probably another one here before because look at all this fluid. These are all loops of bowel floating in free fluid. So that's ovarian cyst with free fluid adjacent to it. And they're measuring it here. It's like almost 2.5 centimeters for that dimension. And then she was pregnant, and we did the ultrasound. We saw this, and then we sent the patient to the operating room. And I got a page from the operating room. Thank you very much, Dr. Fox, for making wine in the OR. What do they mean by that? What's the diagnosis? Grape-like structures? What's that? No, it's not a... Have you heard of, maybe you don't know what this is, a molar pregnancy? Have you heard of that? Where it's like trophoblastic disease, and the embryo just keeps on, it's basically like the embryo turns into be like a tumor. It just starts dividing and going crazy and taking over the uterus. And so they have to go to the OR because all of these are very large. It can take out really big blood vessels and you can die from it. Yeah, it was just a normal intrauterine pregnancy that just started dividing the cells. It turned into like a tumor and started invading the walls of the uterus. And so you can have a lot of bleeding, the patient can die. So you have to go into the OR and scrape that whole thing out. Or molar pregnancy. Sometimes you need hysterectomy. Yep. Sometimes you can save the uterus, sometimes you can't. So, how about this one here? This is the uterus. This whole thing out here is the uterus. This is the gestational sac. And inside the gestational sac, we see a little yolk sac, a fetal pole. You can see part of the amnion right there. That fetus, the next question is, does it have a heartbeat or not? And I don't know if I see a flicker there. Sometimes I do, sometimes maybe I don't. That's the next question. It's definitely an intrauterine pregnancy. Whether it's live or abnormal is the next question. Because if it's 5 millimeters internal diameter, then it better have a heartbeat. If it doesn't, it's going to become a miscarriage. See hyperemic blood vessels surrounding an ectopic pregnancy, that tells you that this is a dangerous ectopic, that this thing is like actively trying to kill its host, and you need to act soon on this and get people involved and help. This helps to convince people that they need to go to the operating room sooner than later. And so this is an ectopic with a ring of hyperemic fire around it. We see this too with acute appendicitis. We see rings of fire around acute appendicitis sometimes as well. Start singing that song, yeah, to the patient. So this is what a pseudogestational sac of ectopic pregnancy looks like. See this? This is the uterus. It's got that very abnormally looking sac to it, but this is the ectopic growing out here. If I back up a little bit, maybe you'll see a little yolk sac. So that's the yolk sac inside this gestational sac that measures at least 5 millimeters of internal diameter that happens to be outside the endometrial echo of the uterus. Okay, so that's why I don't just look at this double decidual sac. It's got a nice thick ring over here. Luckily, there's nothing in it, and we maintain our vigilance and looked for an ectopic pregnancy. Make sense? A couple more cases, or move on to the thyroid. This is a patient who I'm looking all through this fetus for a heartbeat. It's at least 5 millimeters of diameter, this crown rump, and I'm just fanning all the way through. So before I tell a woman that she's going to have a miscarriage, I actually do spend a good 3 or 4 minutes doing one of these ultrasounds, just fanning all the way through, trying to find a heartbeat. And this turned out to be an abnormal in-uterine pregnancy, which once it meets that criteria, 100% go on to become miscarriages. This was probably my most interesting ultrasound ever. This is a uterus over here, okay? 4 days ago, she went for an abortion. She came into the ER, still having vaginal bleeding. This is her uterus. This is a loop of bowel, and this is a pregnancy. What makes this very interesting is not just because, but because of this patient's anatomy. So this is actually another uterus, or uteruses, or uterus. So she actually has 2 cervixes and 1 vagina. So you put the speculum in when you do a pelvic exam, looking for a cervix to pop into the speculum, and when that cervix pops in the speculum, it's not human nature then to keep looking for another cervix somewhere else. And so what happens is you figure, oh, I found the cervix, that must be the uterus, and that's the thing I'm going to scrape. And unfortunately, for the patient, she had another uterus that nobody knew about until she came into my ER, and we found this other uterus, and a baby was growing. As like a sign from whoever that this was like, I need to keep this, hang on to this pregnancy. So I don't know if she did or not, but this was is an interesting diagnosis to make. Another example of very large ectopic pregnancy, just to let you know that ectopics can grow pretty big. This one has a heartbeat to it. This is a live ectopic pregnancy, maybe in the 10 week range. Now, this is another very large ectopic, a 12-week live ectopic. You can see it's actually moving around. So I'm on this airplane editing this video that you see here, and I'll never forget this. This woman, I'm sitting in a middle seat, of course, as usual, and the person next to me is looking at my ultrasound. They're saying, "Oh, is that your baby?" I said, "No, that's not my baby, but this is a baby. You can see." She goes, "Oh, yeah, I can see it's moving all around." The woman to my left is looking at it too. She's like, "Oh, yeah, I can see that. Look, there's the baby's head. It's like moving and waving." And they're making little sounds like you guys are making right now, like, "Oh, look at the baby." And then the flight attendant comes walking over, and I said, "Yeah, well, what's really interesting about this baby is that it grew to 12 weeks without being in the uterus. It's growing outside the uterus." And the woman to my right says, "How does the baby crawl back into the uterus? What do you do?" And I said, "Well, it doesn't work that way. The baby can keep growing, and you have to terminate the pregnancy, or it can kill the woman." Well, the mother, and this woman got very upset about that she was looking at a live baby that she kind of bonded with, that's now, and then the flight attendant gave me this look that could only mean, you could have said it was an ectopic kind of look, you know. So. Anyways, to summarize this pelvic stuff, this is really all you need to know. That a live IUP, just to review, is a 5 millimeter gestational sac with cardiac activity, whereas an early IUP is a 5 millimeter gestational sac that has at least a fetal pole or yolk sac in it. Once that gestational sac grows to 10 millimeters without anything in it, or a fetus itself grows to 5 millimeters without a heartbeat, it's going to become a miscarriage 100% of the time. An ectopic is where it sounds just like an intrauterine, except it's outside the uterus, and if it doesn't meet any of that above criteria, it's no definitive IUP, and it's got an up to 40% ectopic risk factor to it. Now, ovarian cysts, I didn't mention this, but sometimes they're symptomatic, sometimes they're not. Pelvic free fluid is the same way. It can or cannot be symptomatic depending. It's weird that way. Blood is always symptomatic though. It's always irritating the peritoneum. The following statement is never true. I just ruled out ovarian torsion with ultrasound. Okay, as much as I love ultrasound, you cannot rule out ovarian torsion with it. What does that mean? When the ovary starts to twist or torse, you're going to hear a lot about ovarian torsion in your careers. As the ovary starts to twist, the first thing it pinches off is the venous structures. The veins twist and become torsed. The ovary starts to enlarge. But when you put Doppler on it, or color, the ovary's got plenty of color to it. And so you falsely think there's no torsion going on there. This happens a lot. You can't rule it out. You can rule it in. If there's no flow to the ovary, you're done. You've ruled in ovarian torsion. But to say I did a normal ultrasound Doppler, there's no torsion, is an impossible statement to make. And beta-HCG should double every 2 days with normal intrauterine pregnancies, but with ectopic pregnancies, it does not. Do you have a question, John?
Yeah, on that pie chart you had an SL-IUP?
Single living IUP. Yeah, that's all. A lot of people use that term SL-IUP. But you could say live, same thing as an LIUP, live IUP. We're changing gears now to thyroid. I'm just going to quickly go through this. There's lots of tests that you can do to evaluate the thyroid, blood tests you can do, and other nuclei tests that I don't really care that much about. But with ultrasound, though, this is where we're talking about today. There's lots you can do with ultrasound. Actually, you can differentiate that when somebody palpates a nodule in someone's thyroid, you can differentiate whether it's solid or cystic or complex or multinodular. And also, you can look at the associated lymph nodes to see if there's any lymph nodal enlargement and differentiate lymph nodes from thyroid lesions, but you can't really tell whether something's going to be cancerous or benign based on the ultrasound, okay? It's accessible, really accessible for you guys, and it's accurate with really describing the overall morphology of the thyroid, which is a huge leg up over the relative inaccuracy of the physical exam when it comes to the thyroid. You can see very small thyroid nodules. Some people advocate for using it as screening for early thyroid cancer, though it's never been really proven to be a great screening tool by the literature because up until now, there has not been widespread availability of bedside ultrasound. So this is what the thyroid looks like. It's a very, very pretty organ. And I'm not just saying that. It really is. A lot of people use that term because it's got this very nice echo texture to it. And it's not unlike another nice, pretty solid organ like the liver or the uterus or something. You can really make out its structure. This is the trachea right here, or other people call it the trachea. I'm not sure why I just said trachea, but that's so today is located lateral to the this thing. And so, I can't say that word for some reason. So here's your IJ, here's the carotid, and you should see the esophagus over here. Thyroid wraps itself around this way. This is the isthmus of the thyroid seen up here. We see this pretty prominently. The thyroid, it's got a lot of vasculature, arteries and veins to it. As you're well aware, this is a vascular, on the gray scale, just a vascular structure going through the superior aspect of this thyroid seen here in a sagittal view. So I always look at the thyroid in two views, a nice transverse. This is what a sagittal view looks like. It's pretty big, stretches across the screen as you'll see today. Now you can grade, when a person's got a nodule that you see on their thyroid, whether it's palpable or something you just notice on ultrasound, it's customary to put color on it, color flow Doppler. And grade 1 is no color flow inside the nodule. Grade 2 is just peripheral color flow. Grade 3 is where the color starts to penetrate the nodule in a moderately rich way, whatever that means. Now, if you have a very vascular rich penetration of the color flow, then that's a grade 4 system. So this is what grade 2 looks like. It's just kind of around the periphery a little bit of this nodule. See, this is normal thyroid tissue here, just that little piece of it. This is this big nodular structure here that is not supposed to be in the thyroid. I'll show you another example. This is the, here's the carotid artery right here. This is the windpipe. This is the thyroid tissue coming along here, okay? This is a complex cyst seen in the thyroid with a hypoechoic component, but this is actually a thyroid nodule over here. This is the thing that they're worried about. Well, when you put color flow on it, you can see here it's got only category 2 or peripheral color flow, and when this was biopsied under fine needle aspiration, it came back as a benign lesion. Now, Doppler category 3, here's this normal thyroid here, there's the isthmus, normal thyroid here, left carotid, right carotid. here's this very large nodule seen here on this thyroid. Well, you put color flow on it. Well, now there's some penetration here, moderately vascular rich on this particular thyroid. This came back as positive for papillary cancer. Here's a category 4, lots of penetrating high velocity flow in this nodule. It's got 2 components to it, 1 component here. This component over here is very vascular rich. This also came back positive for malignancy. Here is another Doppler nodule seen here on grayscale, seen with nice color flow. This was category 4. After fine needle aspiration, came back as papillary carcinoma. So what are some red flags concerning these nodules that we get a little bit worried about cancer with? Well, male, extremes of age. So when you're really, really young and you have a thyroid nodule, or you're older than 60, if it changes rapidly over time, you see a patient in your clinic, they come back in 2 weeks, it's totally different looking. That's concerning for cancer. Any nodule that's more than 4 centimeters is going to be a problem. And any symptoms of local invasion, such as it sits right next to the esophagus, so you can have some dysphagia, difficulty swallowing, or changes in the voice. Now, whenever you do a biopsy of the thyroid, the good news is they come back benign, about 69% of the time, and then you got to follow those up in about 6 to 12 months and redo it to make sure that it was still benign. You get an insufficient result about 17% of the time. You get something that's suspicious about 10% of the time. Most surgeons will elect to take those patients to the operating room and take them out anyways, and then you get malignancy back proved on fine needle aspiration only about 5% of the time. Now you're probably wondering some other things, like what does Graves' disease look like on the thyroid? Graves' disease, in addition to people having really interesting looking eyeballs, Graves' disease looks like this. You've got a lot of high vascularity. The whole thyroid is enlarged rather than just being one little nodule like you see with those nodules. Graves' disease is enlargement of the entire gland with lots of flow there. Another concern, if you see punctate hyperechoic regions in a thyroid nodule, if there's no comet tails, that's suggestive of malignancy. This one came back as papillary carcinoma. When you look at this nodule over here, we can see there's some punctate echogenicities, but these punctate echogenicities are a little bit different. They have comet tails coming down from them. Do you see that little comet tail coming down? There's actually another comet tail coming down over here, and this one turned out to be benign. So no comet tails. No comet tails bad. Good comet tails when it comes to these punctate echogenicities. Okay? Just a couple more here. This is another solid nodule. It's very smooth looking. You almost like in the center. Well, in these cases, fine needle aspiration is not indicated because we see these all the time. They're just cystic structures. You can follow them later in 6 months or so and take another look at them, but really they're of no clinical significance in order to do a fine needle aspiration. And people come in, patients will feel something in their neck, you look at it, it's this huge cystic structure there, and there's really not much to do. But if it gets so big that it causes hoarseness in the voice or dysphagia, then a lot of times they're drained percutaneously through using ultrasound. This is just one that we saw a goiter. We didn't put any flow on it, but this person had a giant goiter with Graves' disease, and we're just looking all throughout this gland and seeing how enlarged it was. It was just kind of interesting to see this uniformly enlarged thyroid. This is another patient who had a complex thyroid mass. We're going to walk over to the other side. So this is the IJ on the right, the carotid, the normal right thyroid, the isthmus. Over here we see all this complex cystic component. This was biopsied and actually came back normal or benign. So today, for the hands-on session, I want you to do a couple things. I want you to get a sagittal view of the uterus transabdominally and a transverse view of the uterus transabdominally, and try to see if you can find the ovaries. That's the trick, is having a nice full bladder, pushing down almost as hard as you can, and adjacent to that full bladder, you should be able to hopefully see an ovary or two today. That's kind of the goal with the pelvis. And then with the thyroid, I want you to take a look at the transverse view of the thyroid, come across, see the isthmus come down the other side, and also look sagittal view of the thyroid on each side to get an idea of its overall echotexture. Thank you very much. Oh, Gracie has a question. Entire gland with lots of flow there. Another concern, if you see punctate hyperechoic regions in a thyroid nodule, if there's no comet tails, that's suggestive of malignancy. This one came back as papillary carcinoma. When you look at this nodule over here, we can see there's some punctate echogenicities, but these punctate echogenicities are a little bit different. They have comet tails coming down from them. Do you see that little comet tail coming down? There's actually another comet tail coming down over here, and this one turned out to be benign. So no comet tails. No comet tails bad. Good comet tails when it comes to these punctate echogenicities. Okay? Just a couple more here. This is another solid nodule. It's very smooth looking. You normally look in the center. Well, in these cases, fine needle aspiration is not indicated because we see these all the time. They're just cystic structures. You can follow them later in 6 months or so and take another look at them, but really they're of no clinical significance in order to do a fine needle aspiration. And people come in, patients will feel something in their neck, you look at it, it's this huge cystic structure there, and there's really not much to do. If it gets so big that it causes hoarseness in the voice or dysphagia, then a lot of times they're drained percutaneously through using ultrasound. This is just one that we saw a goiter. We didn't put any flow on it, but this person had a giant goiter with Graves' disease, and we're just looking all throughout this gland and seeing how enlarged it was. It was just kind of interesting to see this uniformly enlarged thyroid. This is another patient who had a complex thyroid mass. We're going to walk over to the other side. So this is the IJ on the right, the carotid, the normal right thyroid, the isthmus. Over here we see all this complex cystic component. This was biopsied and actually came back normal or benign. So today, for the hands-on session, I want you to do a couple things. I want you to get a sagittal view of the uterus transabdominally and a transverse view of the uterus transabdominally, and try to see if you can spine the ovaries. That's the trick, is having a nice full bladder, pushing down almost as hard as you can, and adjacent to that full bladder, you should be able to hopefully see an ovary or two today. That's kind of the goal with the pelvis. And then with the thyroid, I want you to take a look at the transverse view of the thyroid, come across, see the isthmus come down the other side, and also look sagittal view of the thyroid on each side to get an idea of its overall echo texture. Thank you very much. Oh, Gracie has a question. And also look sagittal view of the thyroid on each side to get an idea of its overall echo texture.